Why are so many couples struggling to conceive, and what does that tell us about the health of women, men, families, and the environment around us? Welcome, everyone, to this week's IMA webinar. I'm Dr. Kat Lindley, Director of the IMA Fellowship Program and Senior Fellow in Family Medicine. Tonight's episode is called The Fertility Crisis: Causes, Clues, and Hope. We are talking about fertility, infertility, and the broader decline in birth rates. This is a deeply personal topic for many families, but it's also a whole body health topic. Fertility is not just about one organ system. It can involve hormones, anatomy, ovarian reserve, sperm health, inflammation, metabolism, environmental exposure, stress, sleep, nutrition, immune function, and the health of both partners. Our goal tonight is to make the conversation practical, honest, and helpful, not fear-based, not shame-based, just clear information that helps people ask better questions and understand what may be affecting reproductive health. One quick note before we begin: this conversation is for educational purposes and is not personal medical advice. Please work with your own qualified clinicians for diagnosis, testing, and treatment decisions. Tonight, I'm joined by Dr. Kimberly Biss. Dr. Kimberly Biss is a senior fellow in obstetrics and gynecology at IMA. She graduated from medical school in '93 and has spent decades caring for women and families. Her work focuses on patient safety, informed consent, and careful review of clinical data, especially in pregnancy and reproductive health. Dr. Biss has presented her clinical observations and practice data to policymakers and continues to advocate for safer, more transparent medical decision-making. She was also appointed to the ACIP committee to advise the CDC on childhood vaccines. Although the committee is paused given a judge's stay, we hope with a recent executive order the committee will be reconstituted very soon. Dr. Biss, thank you so much for joining us.
Thanks for having me on.
Thanks for coming on, Kim. So Dr. Biss has prepared a presentation for us tonight, and she's going to walk us through the bigger picture: declining birth rates, what infertility actually means clinically, common female and male factors, lifestyle and environmental exposures, and some of the emerging questions she's watching in the research. So for now, I'm going to turn it to Dr. Biss, and after her presentation, we'll have some questions to go over. Kim, go ahead.
Well, let me share here. And sorry, it didn't start it at the top. Okay. So tonight we're going to talk about briefly infertility, fertility, etc. I mean, this is a 3-year fellowship that reproductive endocrinologists take, so I'm certainly not going to touch on everything. I wanted to start off with this slide. There's a great Substack that everybody should read, and it's referenced at the bottom of the slide. It's Focal Points by Nicholas Holscher. And this is the slide showing now what our birth rate data is in the United States. And, you know, we've slowly been declining with birth rates, as you can see, starting shortly after 2006. But we've now reached a point where our births are not exceeding our death rate. So the United States of America now is starting to depopulate. And I read somewhere that in order to maintain our population, every woman in our country of childbearing age would have to have 2.5 children. So this is truly a crisis at this point. So just some pearls when we talk about fertility and infertility. So when at the top of the pyramid there shows, um, the causes, who can be attributed the cause of infertility. So it's evenly split, 33 and 33% female to male. Combined would be 20%, but then sadly the remainder is unexplained after the couple's undergone a workup. In normal couples, conceptions, usually 80% of those will occur within the first 6 months of trying for conception, and 85% will occur within the first 12 months. Now, how is infertility defined? So if a couple has been trying for 12 months, and the woman's less than the age of 35, that would be the diagnosis of infertility. Once the woman's over the age of 35, we don't wait that long to initiate a workup, so that would be by 6 months. The fertile period is cycle day. To make it easy, I mean, I know you can use apps on your phone and you can buy ovulation kits, etc. But when I counsel my patients and they're having, normal cycles every 26 to 30 days, I tell them to start counting out, their cycles. And cycle day number 1 would be first day of your menstrual period. So when you get to cycle day 10 through 20, that would be considered your fertile period, because not everybody ovulates exactly in the middle on cycle day 14 through 15. You may ovulate sooner or later, and sperm lasts for a certain amount of days. So, you don't always have intercourse right on the day when you ovulate. So I give them a window of time. But if their periods are shorter than every 28 days, then their fertile period would be 5 days prior and including their day of ovulation. And you can use basal body temperature and cervical mucus to kind of know when you're ovulating. Women and men are different with regards to what we produce and regenerate. So women do not regenerate eggs. All our eggs are produced by the time we're developed in the womb at 22 weeks, which is a little over halfway through pregnancy. And we start out with around 7 million eggs. But when we're born, that figure goes down to 1 to 2 million. And by the time we reach puberty, that number goes down to 300,000. And with every cycle, we lose a few of those eggs. So we're down to 12% of what we started with by age 30, and by 40, that's 3%. And menopause is defined when there's no further oocytes left, and that's usually on the average ages of 51 to 52. Now, on the other hand, men regenerate their sperm. There's 100 to 200 million produced daily, and they take 64 to 74 days on average to mature, so they're stored in the epididymis. And what I tell patients when they're trying to conceive, don't have sex every day, because that's not enough time for the male to regenerate enough fully mature sperm, so he's going to be shooting blanks, I say. So what are the causes of infertility? So there's anatomical causes, systemic, genetic, lifestyle, and other exposures. And then, of course, there's unexplained. And that applies to both male and female. So in the female, when we're talking about anatomical causes, and where I could find a percentage of cause, I have in parentheses. So the ovaries are a quarter of the reason in women with anatomical issues, and that is broken down into either they're not ovulating properly, or they don't have enough what we call ovarian reserve, which is eggs that are left. Fallopian tubes are 22% of the cause, and that would be scarring of the tubes, which usually is from a pelvic infection or may arise from having appendicitis in the past or having previous surgery. The uterine factors would be fibroids or polyps. There are some women that are born with anomalies of the uterus. When we are developing in the womb, our uteri actually uh, originate from two halves of the uterus that fuse during the development process. So you can imagine if that fusion doesn't occur properly, you can have some anomalies of the uterus. The main one that causes issues with fertility are those that have a septation, which is a division down the middle. But there could also be scarring in the uterus that can occur from either infection or previous surgeries like a D&C. The cervix may have scarring, which is otherwise known as stenosis, and that can happen from previous surgeries or infection. The mucus of the cervix may be poor, so if the cervical mucus is very thick, that's not going to allow for sperm to enter into the uterine cavity. And of course, there could be an active infection that the woman doesn't have any symptoms of, but is present. Um, I also put down here endometriosis. That's about 15% of the cause, and that can lead to adhesions, but adhesions or scar tissue could develop from infections and previous surgeries. And the reason endometriosis is the cause is not only due to the scar tissue it may develop, but also it allows for certain chemicals called cytokines and other factors to be in the pelvic fluid, which is not going to allow for fertilization to occur. Did I skip a slide? Yeah, so ovulatory dysfunction. So this is focusing on the ovary. So there's many reasons why a woman won't ovulate, and the most common would be due to pituitary reasons. So women who are under a considerable amount of stress, or they have a very rigorous exercise routine, or they have an eating disorder, anything that's going to cause their body mass index to be severely low. That's nature's way, really, of not allowing a woman to become pregnant. They could have high prolactin levels. Prolactin is a hormone that's created in the pituitary gland in the brain, and that's what's elevated shortly after pregnancy because that's what causes us to breastfeed or lactate. So it's going to be high if they're currently breastfeeding, but there's also tumors of the pituitary called adenomas, which can allow for elevated prolactin levels. There could be trauma, head trauma from a previous accident, or the other trauma to the pituitary is if there's a significant amount of blood loss. This can especially happen after delivery if a woman has a significant hemorrhage, and that can result in a lot of pituitary hormones no longer being made, and that's called Sheehan syndrome. And there's also autoimmune conditions that can affect the pituitary gland, so those hormones aren't released that go and stimulate the ovaries to produce hormones and ovulate. Specifically to the ovary, polycystic ovarian syndrome, which actually there's several bodies now that want to change that to polyendocrine metabolic syndrome because there's other things involved, just not the ovaries during that syndrome. But that syndrome occurs in 5 to 10% of women. And basically what's happening there is the chemical connection between the pituitary and the ovary is not working properly. So women don't ovulate, thus they don't have regular menstrual cycles. They usually have very high levels of male hormones. So a lot of those women will have abnormal hair growth and acne. And an ultrasound will usually demonstrate multiple small follicles on each ovary. Because they have an elevated androgen or male hormone levels and some effects on the pituitary as well, they also have insulin resistance and some metabolic issues, which is why they want to change the name of the syndrome. and long term that can lend towards cardiac disease. Their ovarian reserve could be low, either because they went through premature menopause or some other issues that I'm going to get to later on in my slide. The ovary could have tumors, or they could have been exposed in the past to chemotherapies for malignancies, or radiation therapy. Other exposures would be drugs, contraception, obviously, but there's other drugs that can affect production of hormones and whether or not a woman ovulates. Just to throw out here as well, if there's any practitioners watching this right now, if you have a young patient that's still of reproductive age and she's been diagnosed with a malignancy, I would recommend part of her evaluation also be by a reproductive endocrinologist, because we should allow her the opportunity, if she wants, to freeze her eggs, because if she receives medication that renders her menopausal, then she would not be able to do that in the future. Systemic causes of ovulatory dysfunction would include problems with the thyroid or adrenal gland, if they're chronically ill with liver or kidney disease or celiac disease. And then there's some autoimmune conditions that can affect that, such as lupus and myasthenia gravis. Genetic and exposure. So Turner syndrome, which is 45X, that's a condition where women usually don't have much of any ovarian tissue. They have streak ovaries, so they're usually not going to be fertile. There's many other genetic causes now that a reproductive endocrinologist would do a whole panel as part of the workup. Certain exposures can cause issues with fertility, and I've listed those there. Diet obviously should be very important. I mean, a normal body mass index, which is not a very good measure, honestly, of our weight, but we should have low to normal body fat, and our diet should be, where I've read in some areas, close to the Mediterranean diet. I mean, basically try to avoid the middle of the grocery store and don't eat a lot of processed foods. Try to limit caffeine, alcohol, tobacco, marijuana. But the other thing I think that's really contributed towards our decreased numbers is the fact that many women are delaying childbearing. They want to get a career before they have a baby. And by the time they sometimes meet their partner and make that decision, they may be in their late 30s, early 40s, and it's harder to become pregnant because they don't have as many eggs left. But there's other issues such as finances and cultural shifts. Now, when we discuss male infertility, the anatomical issues are listed here. So the most common issue would be related to the testes, and there's many reasons why perhaps there would be an issue with sperm production, or how the quality of the sperm and the motility of the sperm, because both are affected, and I've listed some terms to the right that discuss that. So there's a pituitary cause, and it's very similar to in female as far as what could possibly be causing the issue with the release of the hormones from the pituitary. There's undescended testes would be an issue. There are certain men who have normal testicular tissue, but for whatever reason, the receptors aren't right with regards to what their male hormones are going to attach to. If they have certain myotonic dystrophies, they are usually not fertile. Infections, which I've listed there, can hamper the development of sperm. Heat's a big thing. So tighty whities, big no-no. Wearing biker shorts, a lot of men are, bike riders, anything that's going to keep the testes close to their torso is going to increase the heat, and that decreases sperm production. Hot tubs are a big thing as well, and there could also be some tumors there. The sperm transport would be the vas, most commonly the vas deferens, and they may have also an ejaculatory issue. And then varicoceles, which are dilated veins in the scrotal area, and more commonly it occurs on the left as opposed to the right. Systemic issues are listed there. Some are similar to the female. The drug sulfasalazine that's listed there, that could also be in a female patient because that treats ulcerative colitis. There seems to be a lot of work done with regards to marijuana, but I jokingly say, Jamaica is not very underpopulated, and they certainly partake, but I'm not recommending that anybody should do that. But I don't really know if that's a huge contributor to infertility. Weight is a big factor with regards to male infertility, and probably because that lends towards a higher rate of diabetes and also obstructive sleep apnea. And then the exposures I've kind of already discussed previously. So what I wanted to discuss now moving forward is obviously what happened in 2021. We were declared a pandemic in 2020 with COVID-19, and then that resulted in the development of the COVID-19 vaccines, which are genetic injections. And I feel that that is a contributor to the fertility problems we're having today, because I saw in my own practice right after these injections started that women were having issues getting pregnant, even though prior to COVID or the injections, they didn't have any issues. And a lot of them needed to proceed with in vitro fertilization in order to conceive. But we knew right from the beginning, Pfizer's own rat biodistribution study showed that the lipid nanoparticles, which is the little fatty envelope that covers the messenger RNA, distributed everywhere in the rats, but concentrated very heavily in endocrine glands, because endocrine glands, like fat, they all use cholesterol in order to make your hormones. And they went very highly concentrated and very quickly in the ovaries of the rats, and also in the male rats, concentrated in the testes. So could that maybe perhaps be an issue now, as many people were vaccinated? We have studies out of Israel showing that men that received the Pfizer product showed not only decreased numbers of sperm, but also decreased motility. They only studied these patients up until 125 days, but that doesn't mean perhaps this didn't extend beyond that time frame. We also have literature showing now, there was another study I don't have listed here, but this was the first one, that these products don't stay in the arm. They do traverse throughout the entire body, and they go into the umbilical cords and into the babies. Another study shown that this has been found in the placentas and in the babies. And that study, sadly, was in moms that were not even vaccinated, but their partners had been. But the reason why I bring this up is because these products are going to the babies, and perhaps these products are going to the baby's gonads, specifically females, which I've already discussed the fact that all their eggs are already made by 22 weeks. So if these products are getting in their ovaries, what does that mean for that baby when she's born? Is she going to be able to go through puberty or have a baby when she's, of reproductive age? This is to credit Nicholas Holscher. Again, this is from that Substack I referenced, but this is a study, the Karaman study that was done, and this was looking at 30 albino rats. They were injected with the human equivalent of the Pfizer mRNA product, and given an injection at one, or given their first injection and then the next 2 weeks later. And this was, all the rats were between 16 and 24 weeks of their pregnancy. And after 4 weeks after they received their second injection, blood was drawn to measure certain hormone levels and other chemical levels, but one that was of most importance in this study was the AMH, which is the anti-Mullerian hormone, and that level is a reflection of how many eggs a mammal has or female has. And they also did biopsies on their ovaries. And not only did the AMH levels become abnormal, but they found that they lost 60% on average of all the primordial follicles, which is basically the eggs that are going to go on and eventually be ovulated. So that was in rats, that wasn't in humans, but they're mammals, and that's concerning. This is the Manish study. This is a study looking at the Czech Republic data on women that had births, and it's showing basically that these are women also that spontaneously conceive. So I don't know how they got that information specifically, but these were spontaneous conceptions and births in women that were vaccinated and not vaccinated. The light blue is the unvaccinated, and you can see moving through time that women who were unvaccinated were more likely to conceive and have a live birth. So this is all going from 2021 when the vaccines were rolled out. Now this is data from the same Substack. However, the data is from a man on X, goes by the Ethical Skeptic, and this is our own CDC data. Now, this isn't on infertility. These are babies that are born, but born to vaccinated moms, and it shows that from age 0 to 4 years of age, so from birth to age 4, the mortality in these children is going up. So this isn't infertility, but this is depopulation. I mean, but this is concerning. Something's going on in these babies that's causing them to pass away. Now this is a little bit similar data. This is out of the Philippines. Sally Clark is somebody who's been looking at the Philippine data since the vaccinations were rolled out in that country. And the concern here is that their infant mortality has been slowly rising since 2021. So there's been a lot of things that have not been going right since these injections were rolled out with regards to, fertility and now the survival of those babies. So that's the end of my slideshow. I know that there's a lot of information there, but it's certainly not all inclusive. I mean, fertility and infertility is a huge topic, but I just wanted to kind of bring light to what I felt was important. So
Great. Thank you, Kim. And thank you for walking us through all this. Now, I want to step back a little bit and start with the big picture, because a lot of people think of infertility as being a narrow reproductive problem, but your presentation showed us that it is really a whole body health issue. Why is it important to make that distinction?
well, I think, as you and I and a lot of have seen ever since COVID, we're allopathic medical model. I mean, we're also focused on our own organ system, right? We just can't think out of the box sometimes. But, obviously, if we're not healthy, that's why on one of the slides I showed, if a woman is severely underweight or severely overweight, that's usually nature's way of not allowing her to have a baby because she's generally not going to be healthy, you know. Um, so yes, obviously the whole body needs to be healthy, not only to get pregnant, but to nourish the baby while you're pregnant, and then to be able to take care of the baby after you deliver the baby. So, diet, exercise, exposures, mental health, all that's important.
Yeah, and especially when you get pregnant, all your system get affected, right? The brain, the
Correct.
fog, the heart has to pump a little bit harder. It's a lot of
Absolutely.
stuff that gets us involved. So when a couple is struggling to conceive, what are the first things you want them to understand?
Well, sometimes too, they'll think that there's a problem, but they've only been trying for like 2 weeks. So you have to kind of reassure them that most couples take more than a month, 2 or 3 to conceive. Um, the other thing, we're not a very good, efficient species when it comes to reproduction because sadly a lot of babies are miscarried.
Mhm.
You have to reassure our patients that not everybody, it's very rare to be a repetitive miscarrier or have, repetitive pregnancy losses. So if you do have a miscarriage the first go round, usually you're going to have a baby. It's not, that's the writing's not on the wall at that point. Um, but if I have a couple that's, the woman's less than 35 and they've truly not been preventing and actively trying for at least a year, then I think at that point it's good to get them established with a reproductive endocrinologist who sees both the male and the female. Most reproductive endocrinologists have their own andrologists that work for them. So those are
Mhm.
scientists that deal with the sperm. They're not going to want anybody to go to LabCorp and get a semen analysis because they're not going to rely on that information. But they evaluate the couple, they test both of the people in the couple, and they come up with a plan. Most of the time they can find an etiology. Unexplained is not that common. Um, and a lot of the times it's due to ovulation. So it's not necessarily that the woman's going to, it's not a given just because you're going to an infertility specialist that you're going to have to undergo in vitro fertilization. So there's other things that can be done. So,
Yeah, and I think having a team that looks at both male and female together and doesn't put blame only on one, because a lot of times when couples are infertile, the woman will think, oh, it's my fault. We kind of
right.
tend to take all this as a burden on our own. So actually, let's talk about female fertility. Your slides covered a wide range of possible contributors, whether it's anatomy, ovulation, ovarian reserve, hormones, inflammation, and all that. What are the most common female fertility issues that you've seen?
So, ovulatory issues like polycystic ovarian syndrome, that's pretty common. Endometriosis is common, but probably not as common as polycystic or some ovulation,
Hmm.
issues. Um, those are kind of probably the top two. Uh, but of late, what's probably more common is, the effects of COVID and the vaccines have
Yeah.
had. So, yeah.
What about the ovarian reserves? When do you do the testing of ovarian reserves?
So that's a good question. I have a lot of patients coming in and asking for that, but the anti-Mullerian hormone or AMH was actually what that's utilized for is by infertility specialists to see if the woman's going to respond to hormones when they're undergoing an IVF cycle. So
Hmm.
they want to see if their ovaries are going to respond to the medications they get that are going to make enough follicles or eggs that they can aspirate and, create the embryos. So it was never designed as a tool, you know, for the general population to see if they have enough eggs or they're fertile, but it's gotten out there that it is. And there's certain things that can affect those levels. So if you're on, currently on birth control, it may affect those levels. If you're, over a BMI of 35, the level could be affected. I mean, there's a menagerie of things, but so it's not like you get it drawn and that means everything's a-okay because it's not really designed for that situation yet. I mean, maybe that'll change, but it's mainly just used by the reproductive endocrinologists.
And when it comes to eggs, what is the major difference between quantity and quality of the eggs? How do you kind of assess that?
So quality, that's a good, I mean, I don't really think you can assess the quality the eggs. I mean, the sperm, obviously, that can be assessed when it's being evaluated in the lab, but the the number we have that we can ovulate from diminishes as we age. And then the other problem is, the older we get, perhaps the genetic material is not going to separate correctly. So that's where you are at risk for genetic abnormalities such as, trisomy 21 and other
Mhm.
trisomies. That is increased with age. When I started 30 years ago, 35 and up is advanced maternal age. And, supposedly all those risks were higher in that age range. But we have a lot of women 35 years, low 40s that get pregnant, and not a lot of them have chromosome,
Mhm.
abnormalities. Probably because a lot of them, honestly, will be miscarried very early. But I would say in my career, the majority of Down syndrome babies that I've seen have actually been younger than age 35, interestingly. But the risk is generally higher in the older woman for that.
So specifically, when it comes to age affecting fertility, what do you wish that women were told? Because I would say a lot of women have been told, you can have your career, you can do all these things, and then you can get pregnant and have a baby. So when they get older, they do struggle. What do you wish that they were actually told?
Yeah, that's a good question. I mean, I'm a victim of that myself. I always thought becoming a wife and having babies was not on the top of my list. I wanted to become a professional, and I did, and I ended up having my first child when I was 30. But I was just of that genre that a lot of us were conditioned to go to college, get a career, and then get married and have babies. And I think that that's really sad because, a lot of women probably didn't want to do that. They probably wanted to marry young and become a mom and take care of the home, but they were made to feel like, if they did that. And I mean, I think that's really sad. I think that if you want to become a professional and delay childbearing, you need to be counseled that the older, I think the age is like 32, 33. That's when it starts to become harder to get pregnant. That's when we discuss fecundity, that's the ability to get pregnant. And the slope on that curve starts to go down once you hit the age 32, 33. So it's harder to get pregnant, but also, women are not getting partners until later. So a lot of them, they don't even meet, their Prince Charming until they're 40, and now they want to have a baby. So it's harder the older you get. So I think a lot of that's societal in our culture, and hopefully that'll change. But um, we at least need to be honest with our patients and let them know they're not going to be able to get pregnant as easily as they would in their 20s.
So I would say, it's kind of easier when someone has issues like thyroid, adrenal, prolactin, or sugar issues, or PCOS, or celiac disease, because then you can kind of figure out, okay, these could be the reasons why they're having issues with fertility. But what do you do when you actually essentially have a healthy woman with regular cycles, but she still cannot get pregnant? How do you deal with that?
Yeah, so a lot of times in that situation, it's going to be male factor. It's going to be due to the male. But I would say like she would have to be evaluated by a fertility. She might be one of those that has a rare genetic issue. There's anti-sperm antibodies, which is not very common, but that could be an issue. Mycoplasma infection of the cervix can be a culprit, and that's not commonly tested for. So that might be one thing you may want to consider ruling out and treating if they have it. I think in somebody who's healthy and getting regular periods, you have to start looking for what we call the zebras in medicine, the things that aren't that common.
Yeah, and actually, I have 5 children. I struggle Well, I never struggled getting pregnant. I could always get pregnant, but I struggled keeping the babies between my first and the second baby. I actually had, I don't even remember, like five, six, seven miscarriages because some of them
Mm,
happened really early on. And I think the furthest I carried was 13 weeks. But I went to see a specialist, and he, at the time, there was some literature showing that people can throw microclots.
mhm,
My blood work and everything was normal, but he was like, you know what, let's try aspirin and give you progesterone to,
yeah.
to create environment where the baby would stay. And actually that helped. So yeah, I know sometimes you really have to look for these zebras because you don't necessarily know why someone can get pregnant.
Yeah, so thrombophilias can be an issue where you have a blood clotting disorder. But I do, for a patient, let's say I've had a patient that had a miscarriage, her first pregnancy. I will sometimes put them on a little baby aspirin for the next one. There's not a lot of science behind that,
Mhm.
but it makes both of us feel better because I'm trying to help her and she's doing something. And a lot of them do conceive on that. When I first started practicing, luteal phase defect, which is where women don't produce enough progesterone after they ovulate,
Mhm.
used to be a thing. Now, a lot of the reproductive endocrinologists don't really believe in that. But we will still give women progesterone, if they've had a previous loss or something. It's not going to hurt. And if it helps, then great. So, you know.
I think that's kind of how I was because it worked with my second one with Maddie's. I was like, when I was got pregnant with the third, fourth, and fifth, I was like, yep, let's do the aspirin and progesterone again. I think it was more psychological reassurance that everything's going to be good.
Yeah.
So definitely. Okay, but let's get back to actually the males, right? Um, so, you did a workup on a woman. We don't find any major issues. How do we now start the workup on a male and kind of, because that can be a very sensitive issue for our male partners. How do we
Yeah.
explain to them this whole idea that we need to count the sperm, look at the motility, morphology, and kind of take it from there?
Yeah, so I don't do dudes in my practice.
I love that. I don't do this.
So that
Okay,
would be
but
that would
what is your talk with a couple to kind of say, okay, now it's your turn.
right.
She did she did her workup.
Right. So I do tell the men that, part of infertility is due to the men. Sometimes though they don't even want to come to the appointment, to see me with it because they're very
Hmm.
proud and, they couldn't possibly be the issue. But if they're sitting in front of the reproductive endocrinologist, they're gonna first and foremost they're gonna want to do a semen analysis on the guy, and look at the sperm, make sure there's an adequate number, etc. And then they probably go backwards from there and do workup, etc. Check for infection, etc. Um, if there is a problem with the number of sperm or the motility, what they'll do then is what's called uh, well, they can do a couple of things. They can gather the most uh, motile and mature sperm, and then do timed insemination, or it's called IUI, or intrauterine
Hmm.
insemination. So the woman's ovulating, you don't have to do anything for her, but basically inject the sperm at the time of ovulation from the sample that the male provided. Now, the other thing you do is ICSI, which is where if the woman is going to undergo in vitro fertilization, they get the healthy sperm from his sample and they inject that into the egg. So, but beyond that, because I don't do that. I don't do fertility in my practice, but I'm pretty sure that's what happens. They probably start with a semen analysis first. After getting a history, of course, they get a history from both, and maybe the male had an infection in the past or previous surgery, or maybe he had testicular cancer or something, and
Hmm.
that would obviously be a reason for decreased production, etc.
So I want to start talking about 2021, but before we go there, there are a lot of young males who now are testing very low on testosterone for
Mm-hmm.
whatever reason, whether it's the 2021 uh, incident, whether it is the fact that our food supply is compromised and things like that. How do you address that when it comes to fertility? Because I think many of them don't realize if you supplement the testosterone, you do risk having decreased sperm production.
Right. So I was listening to a podcast a few years back. A urologist was giving it, and they were studying in World War II all the vets at that time, which most of them were, 18 to 20 years of age. And they were measuring all of their testosterone levels. And the average testosterone level at that time was 1,000 or over. There's no way in hell you're going to find that today. I mean, you're
I
lucky if
know.
your level's 200, you know?
Yeah, I do
And
testing all the time, and it's younger and younger men that are having extremely low testosterone, which I've never seen before.
so I think a lot of that's attributed to the food. A lot of it's heavy on the soy. Okay, so that's going to disrupt the male endocrine axis. Certain clothings we wear, all this sports
Mhm.
clothing that's wicking, that's basically plastic, right? So the microplastics, etc. Um, a lot of guys put their cell phones in their pockets. So who knows? I mean, it's right next to their testicular area. So who knows if
Mhm.
that's a problem too. So I think there's a lot of environmental factors that were in play way before COVID. I think, males' levels have been going down throughout time. And, I think there's a lot of men that are much more effeminate now than they were in days of old, and I
Mhm.
think it's because of those things. So that's tough. You're right, because then if you give them supplementation, but I don't know if that's, normal to bring them to normal levels. I mean, certainly the gym rats that are, juicing, obviously, but I think if
Mhm.
maybe you bring them to normal levels, it should do the opposite.
Okay, so now let's go to 2021. You and I
Mm-hmm.
have done a presentation together. Actually, you've done presentation. I just asked questions on your experiences after the rollout of the vaccines and the number of miscarriages that you were seeing in your practice.
Mm-hmm.
Uh, I kind of know how you handle this because I know you well, but how do patients actually have a conversation with their own physicians and bring up these issues? Because I think we do need to start having more and more of these conversations about infections, medical exposure, vaccination, and medications that are causing some of these fertility issues. How do we
Mm-hmm.
protect patients from just being dismissed and said it's all in your head, it's not real?
It's sad because I would say today, I mean, it's still probably 1% of all the physicians in our country that think like you and I and recognize that maybe there's a problem here from this intervention we did around the globe in 2021. But most of the other physicians that we know in our communities don't feel like that's a problem. I will tell you that most of the reproductive endocrinologists in my community recommended that all their staff be vaccinated. They recommended that their patients be vaccinated. I get 7 and 8 page consult letters from these physicians today, and there's not one mention of whether or not the patients had COVID or were vaccinated. I mean, that's not even on their radar. So I don't know how to answer that question because the
Mhm.
majority of mainstream physicians don't think that that's an issue, which I can't even believe because you can't get in to see a cardiologist, a neurologist. I mean, they're all so busy. Why is that? I mean, nobody's connecting these dots. There's so many patients that have been, injured by these injections or even by COVID itself, but it's all due to, the spike, etc. But they're still not connecting the dots. So,
Yeah, so I think it's time to bring Autumn to ask us questions. And while she's getting ready for that, um, just give me a 90-second intro you give to a patient, to patients who come into you as a couple who's been trying to get pregnant for a while? What is your kind of introduction
Cursory.
into, yeah, like how do you approach it? Because I know it's very kind of, personal, scary. You almost feel like you're failing at your, you know, biblical thing that you're supposed to do. How do you actually reassure this young couple or even older couple that, there are answers, there is a road ahead that they can take and you'll be with them?
Yeah, so I usually, get a cursory history from the male. I want to, have you ever fathered any other children? Maybe he was in a previous
Mm-hmm.
relationship. Any infections, any surgeries, malignancies, what meds are you on? Do you smoke? The heat issue, ask about biking,
Mm-hmm.
etc. With my patient, I ask, I would probably know, but like, are your cycles regular? What medicines is she on? I review all those. A lot of times too, they may be having intercourse in the wrong time. or they
Yeah.
may or they may be using an app or a stick they pee on, and that's the only time they have sex. So they're probably missing the window of opportunity. And the other thing, I try to reassure them, because a lot of people, they make, I tell them too, by using these apps and the sticks and the everything, they make it like it's a scientific project. This is a natural thing that can happen between a male and a female, and you don't have to bring all this technology into it, because I think that screws with your mental health. And then that is probably what's preventing, because I'm sure of a lot of couples that went through years of fertility treatment, and they finally gave up or ran out of money, and then 3 months later they conceived on their own because they just weren't
Or,
even thinking about it anymore.
or they adopted a child because they were convinced they will never have their own child. And then, like 2 months
And then
later,
they get
she
pregnant.
gets pregnant. Yeah,
Yes.
I've had patients like that. So, yeah,
Yeah.
I always tell them, like, your brain can do so many tricks on you and you just need to relax.
Yeah. So that's my cursory. And then if I think there's, a real issue, then I would refer them to a specialist. So,
Great. Okay, Autumn, we're ready.
Hello. All right. The first question that I wanted to ask, Laura Chamberlain asked Dr. Biss, what is your initial workup of a woman with previous pregnancy prior to COVID with infertility who has had the jab?
yeah, so that's a good question. I mean, I would look for all, the usual suspects first. Like I would, I'm trying to find my plug here because it says my battery is going to die. So pardon me. But
Go
We don't
ahead.
want
That's
that.
important. Find the plug.
and my
She did
desk is
this
on
last
top.
time, just so you remember. I don't know if you guys remember, but
Did
last
I do
time
it last time?
you did, and you had to look for the plug. I don't know if it was during live or
A
the
recording.
practice. Yeah,
Oh
but you
my
were looking
God.
for a plug.
This is so embarrassing. Um, so yeah, so I would look for the usual culprits. Like I would check their thyroid, um, look for, I ask about any clotting history in the family or the patient, and would look, make sure they don't have any clotting issues, rule out any infections, all the usual basic GYN stuff.
Hmm.
I ask all my patients whether they've had a shot or a COVID infection, because that's part of their history.
Hmm.
And then if they have had the COVID shots, I do bring up, um, diet, make sure their vitamin D levels are up, may or may not try a course of ivermectin, because sometimes just doing a week of that may help, or something that's going to decrease, spike. Um, but if my whole workup is fine, and they still can't, they can't conceive, with some things that, if I'm making sure they're having sex in the right time, etc., then I, send them off to a reproductive endocrinologist for further evaluation, because I can't evaluate the guy either. So the sperm,
Right.
that's going to have to be looked at.
So actually, Autumn, I have a follow up.
Yeah, go ahead.
If you can remember, I'm kind of putting you on the spot. Uh, if you had patients like that and they actually had a workup, was there something that you or the specialists have done to actually help them get pregnant, or they didn't get pregnant? If you
With
remember
who?
any of your patients, the ones that had the COVID shot, they could not get pregnant. You send them to, you know,
Honestly, most of them have ended up getting in vitro fertilization, sadly. There's
okay.
not one reproductive endocrinologist I know of that's talking about spike protein or anything like that. So, yeah. And I haven't had any where I have colleagues that have done like a week of ivermectin, and that's been helpful to their patients. But I haven't had enough people to where I've seen that.
Ellen O asked, what are some hormonal or other markers to test for with PCOS to assess postmenopausal health and thyroid health? She said in New York State, there are crazy laws that restrict every lab that does real, thorough testing. Most I've heard about PCOS is about losing weight or having children. Neither are relevant for me.
Yeah, so there's a full panel I draw for polycystic ovarian syndrome. It's male and female hormones, and I also look at prolactin and some other pituitary hormone levels. And also, I think it's important to check a fasting glucose and look at their insulin levels because they may have a element of insulin resistance.
Mhm.
If they are overweight, I mean, studies show even if you lose 10 pounds, that may trigger an ovulation. But if they're normal weight, then obviously that's not going to be the answer. Sometimes incorporating like a metformin, which is, you know, usually for adult onset diabetes, but that has been shown to help with ovulation as well because of the insulin resistance. So I do a whole panel. I also will do an ultrasound, although women can have polycystic looking appearing ovaries and not have polycystic ovary syndrome. So that's not always going to give you an answer. But I do one anyway, just to be sure there's no other structural things going on in the pelvis. Um, so I do a workup, and then I will, before I send them to a fertility specialist, I will do 3 rounds of Clomid, which is an ovulation induction drug. But I
Mhm.
use very low doses because the higher doses require surveillance. You don't want to give them ovarian hyperstimulation. And you always have to counsel the patients too. That increases their risk, not very high, but of multiple, usually twins. So you have to make sure you tell them that. And if they don't have a pregnancy after 3 months, then I recommend they see a fertility specialist.
An anonymous attendee asked if a woman is taking SSRIs during pregnancy, can that affect the brain of the child? I know many doctors claim some of these medications are safe for pregnancy, but what are your thoughts on that?
So Adam Urato is somebody everybody needs to look up. He's a high risk obstetrician who also was appointed to the ACIP committee. He actually has testified for the FDA regarding this because there are studies in rats that show pregnant rats taking SSRIs, and then they look at the fetal brains.
Mhm.
They are affected. The development of the brain is affected by these drugs. Um, and I think, I'm not 100%, but there may be some MRI on human baby data that may show this, but I'm not 100% because a lot of what he talks about is on rats. But there's definitely literature showing they're not as safe as we've been told patients that they are. Mental health, obviously, is very important. I counsel my patients regardless of what meds they're on. I mean, any medicines they're on that they can possibly get off before they get pregnant is a good thing. It's very hard to stop antidepressants once they're pregnant. So ideally that should happen prior to pregnancy.
Mhm.
Some women do stop as soon as they get pregnant and they do okay, but there's others that have issues when they do that. Fetuses also, once they're born, they can have issues with withdrawal because they don't have the luxury of weaning off the drug. Once you clamp the cord, that's it. And some of them end up in the NICU because they have a withdrawal syndrome. So they're not benign drugs. And the problem is they're so heavily prescribed. Um, and I would say there's a huge percentage of my patients that are on them.
Yeah,
So,
it's very easy to get a prescription for. don't need very many pre-existing conditions in order for them to prescribe it to you. So the last, it's not really a question. It's more of if you guys just have any advice for her before I move on to closing announcements. Sophie said, I'm 30. I got vaxxed multiple times, went through 2 years of amenorrhea. I might be pronouncing that incorrectly.
Amenorrhea.
Thank you. Finally started getting periods again with the help of BHRT, but my cycles are horrendous for me and can be 9 days long, all the way up to 39 days long and anywhere in between. Spike levels are still high despite I Recover protocol for years. Do you guys have any advice or words of wisdom for her?
That's tough if her spike levels are still high, you know. The only other thing I could suggest maybe, there's a product called DIM, diindyl methyl something. It's derived from cruciferous vegetables, DIM, and that's supposed to kind of eliminate a lot of the breakdown of estradiol, which is your active estrogen, into the bad estrogen, estrone. So it keeps a higher level of the good estrogen, and that might help with her periods not being as heavy. But as far as the spike, if she can't get it down with our protocols, I don't know, you know, she may, I'm hoping that that thing that Lindsay's going through over in Japan might become a thing with the plasmapheresis and everything for patients that we can't lower their spike levels, you know.
Well, Dr. Lindley and Dr. Biss, do you guys have anything that you'd like to leave our audience with before I move on to closing announcements?
I'm good. Well, I would say thank you for joining us. And as I shared, this was pre-COVID, but I struggled through infertility issues as well. Mainly, I had miscarriages. Like I said, I could get pregnant, but not carry the baby. And it was very difficult, very hard, but you kind of get through it all. And, you know, the most important thing is take care of yourself and find healthcare professionals that are kind of on the same page, that listen to you and your concerns, and don't blame yourself. You know, things happen, and once you actually let it go, one of my kids' favorite song was from
Frozen.
I was going to say Frozen.
Frozen, yes.
Let it go.
And my son made up his own words, but it's really true. Once you let it go, things tend to work out for themselves. So, you know, that's really it.
Sounds great. Ditto.
All right, I am going to move on to our closing announcements, but thank you so much, Dr. Lindley and Dr. Biss, for sharing all of this important information.
All righty, thanks.
Thank you.
All right, we have an exciting update for everyone who has been asking about this year's IMA conference recordings and accredited medical lectures. I'll get to that gut health one in just a second, but I just wanted to let everyone know that we are on track to have the full conference available on our website next week for free for on-demand viewing with a suggested donation to support this important work. Oh, how long have I been muted for? I'm not sure where I got cut off, but for those of you who are interested, we do have the full conference available on our website next week. We're for on-demand viewing with a suggested donation to support this important work. We are genuinely grateful to Loma Linda for working with us through this process, and we're in the final stretch now. So keep an eye out for that posting on our website. All right, now to tools and guides. We recently published a new guide authored by IMA Senior Fellow, Dr. Christina Carmen, called Gut and Metabolic Health, Nutrient-Rich Foods for Gut and Metabolic Health. This guide breaks down 5 foundational supports for digestion, microbiome balance, and metabolic health, including collagen, digestive enzymes, fiber and prebiotic fiber, and probiotics. You can download this guide at, sorry, something in my throat, imahealth.org, or by scanning the QR code on screen. Next week, join us for Ivermectin, the good, the bad, and the emerging science on Wednesday, June 10th at 7 p.m. Eastern. Dr. Joseph Roan, IMA President and Chief Medical Officer, will join Dr. Ryan Cole, IMA Head of Medical and Scientific Affairs, for a timely conversation on what the evidence shows, where the debate stands, and what the emerging science may mean for patients and practitioners. If you haven't already, you can register now at imahealth.org/weekly webinars, and we hope to see you there. All right, last but not least, thank you so much for watching this episode, whether you're here with us live or catching the recording. Thank you for standing with us as an organization. IMA depends on generous donors like you to keep independent medicine moving forward. If you're able, please consider making a gift at imahealth.org/donate. Before we close tonight's session, we wanted to highlight that earlier today, Dr. Angus Dalgleish, IMA Senior Fellow of Oncology, testified at Senator Ron Johnson's hearing and raised important concerns. So to close, we wanted to share a clip where Dr. Dalgleish talks about how he became involved in this important work and why it matters. Thank you all so much for being here tonight. Let's take a look.
I'm Angus Dalgleish, and I'm now Emeritus Professor of Oncology at St George's University of London, and I'm a practicing clinician in oncology, but I've also had first-line experience in immunology and virology, which is one of the reasons I have become very interested in viruses and how viruses cause cancer and the role of the immune system. So that's how I got involved in bringing a lot of these subjects together. The incidence of cancer is certainly going up. When I was starting to think about going into cancer, it was about 1 in 10 of us would eventually get cancer, and that was very much because people would live longer and you're more likely to get cancer as you get older. But, you know, while I was training, it was very obvious that this didn't hold up, because it was, to me, just say 2 decades ago, it was already up to 1 in 5. And I think a decade ago, it was like 1 in 2 people. It's not unusual, you know, even in your social groups, etc. Since 2021, 22, the increase that's been going on for a decade has inflected and suddenly become worse. So the cancers are actually presenting younger, and they're presenting more aggressively. And I, for one, basically, with others, have linked this to the timing is completely consistent with the introduction of the booster vaccines for COVID, which in my belief should never ever been given. It was amazing to me that everybody rolled out these boosters. Now, in Japan, they've clearly shown that the increase in all cancers correlates with the number of boosters. It really is very good correlation, which has been seen elsewhere. So that's that's really is kind of my specialty at the moment, is here's another known oncogenic agent. Stop it, get rid of it. I mean, it took us 20, 30 years when we realized that smoking was likely to be the cause of cancer before it was accepted. My fear, it's going to be a long time too before what is obvious to those at the coalface becomes accepted. And in the case of lung cancer, it was the force of the tobacco companies saying there's absolutely no evidence. And in the case of the vaccines, it is the big pharma making them who keep saying there's no evidence. I have a background of many different vaccine types, and I'd been on the board of a messenger RNA vaccine company. So I knew downside more than most clinicians and people advising the government. And to be quite honest, my experience was they're not fit for purpose to even consider for infectious diseases, because they were on the cusp whether they were safe enough to use as cancer agents. So, and I had a big insight as to knowing why. And you cannot control messenger RNA if you stabilize it, which you have to do to use it as a gene therapy, because that's what it is. And RNA integrates at random. You cannot tell it where to integrate. So the fact that it's integrated into the genome at random, by definition, it could be next to an oncogene, switch it on. It could be next to a suppressor gene, switch it off. And that's exactly what happened. And that's before we got to the fact these vaccines were horrendously contaminated. The quality control was absolutely diabolical, you know, with levels of far more than any circulating DNA and all sorts of toxins. And Pfizer, there's SV40, promoter, not the virus, it's important, but the promoter. But that's enough. What on earth were they doing, allowing that to be in their mixture for an infectious disease, giving them to children who are never going to die of the COVID? I mean, this is negligence on a scale that I think is criminal. This is really big. You know, the damage in the US, I mean, it's millions of people's lives have been destroyed with the vaccines. And the idea that that the vaccine saved a single life, I think I'm not prepared to accept that at all, because it's all based on computer modeling. That is absolute nonsense. You cannot deny the link now. It is overwhelming between booster vaccines and the rising cancer incidence. And it also goes with having reduced the age at which people are presenting, increased the stage at which they're coming. We're seeing a totally different, it's just unbelievable. And it cannot be just put down to all the other factors. This is not quackery, this is not exaggeration. This is a steam train coming down the tracks, and you must stop the vaccines now and instigate programs for detoxifying the damage that this circulating messenger RNA is doing to these people. Or if you think it's bad now, it's going to be so much worse in the future. There's still a window to do something about it.